Welcome to the Modern Gastro podcast, a GI community chat hosted by Commonwealth Diagnostics International. I'm your host, Craig Strasnick. I'm the president and CEO of CDI, and I'm thrilled to have you join us here today. Modern Gastro is a series of educational resources for the GI community, including podcasts, magazines, and email newsletters, all with a focus on functional GI trends and insights from experts around the globe. In each of our GI community chats, we dive deep into the world of gastroenterology, bringing you enlightening discussions with industry experts, healthcare professionals, and thought leaders who are making a difference in our field. Joining us today is Dr. Nitin Ahuja, a distinguished gastroenterologist and assistant professor with Penn Medicine. Dr. Ahuja, welcome to the show.
Thanks very much.
Today, our topic of discussion revolves around a condition that affects millions of individuals worldwide, irritable bowel syndrome, commonly known as IBS. We'll be diving deep into the diagnostic and treatment strategies for IBS, as well as exploring its relationship with another intriguing condition, small intestinal bacterial overgrowth, or SIBO. Dr. Ahuja, let's start by discussing the current landscape of IBS diagnostics. Can you provide our listeners with an overview of the diagnostic methods commonly used and any recent advancements that might have caught your attention in this space?
Sure, yeah. I think to start with, a sort of conventional thought about diagnostics in irritable bowel syndrome is to think about the tests that you employ to exclude other causes. So things like an endoscopy or blood work to rule out anemia or blood work to rule out celiac disease. I think the newer paradigm that's kind of exciting is to think about specific biomarkers of irritable bowel syndrome that might be useful for phenotyping the disease in order to pursue more precise therapeutic approaches. So just for example, there's a lot of interest in the gut microenvironment and specific microbial signatures that might correlate with symptom phenotypes. There's multi-omic approaches, so moving beyond just microbial signatures to the metabolites they produce and whether that leaves a signature that we can somehow measure. But I think it's also worth thinking about a broader definition of biomarkers to include low-tech things like psychological surveys, which have been around for a while, but can also give us a sense of whether a patient with irritable bowel syndrome might be manifesting with a high burden of depression or anxiety that might predispose them to unique behavioral interventions. So it's a wide open space and really exciting to see what's developing.
It most certainly is. I couldn't agree more. I appreciate those insights. I could pick up on a number of the topics that you just touched on, but I think maybe starting with the last area is one that is growing in terms of its recognition, and I think some embedded education across the provider community, but the connection between digestive health and mental health or psychological distress. I'm just wondering, maybe generally or specifically, whichever you prefer, that growing recognition of the connection between digestive health and mental health. Could you maybe elaborate a little bit on how that connection and how maybe improving digestive health could possibly impact one's overall well-being psychologically and vice versa? Generally speaking, I think we've transitioned now from a lexicon perspective from the functional GI patient to the DGBI patient, right? The disorders of brain gut interaction. And so, there's some real aspects to that can be embedded clinically as a standard of care in the future as the data continues to validate that approach. And I'm just wondering if that's something that you're currently utilizing as a routine workup in some of these GI patients, if you think that the jury is still out there, and if you are using it, how you see it working best.
Yeah, I mean, I think the sort of semantic point that you brought up is a good place to start. I think switching from the language of functional GI disorders to disorders of gut-brain interaction has been really empowering in terms of reseeding some of these symptoms and some of these connections in the body and unburdening ourselves of the baggage of stigma that some patients feel in being told that there aren't good biomarkers for their symptoms, and therefore the symptoms reside largely in the psychological domain. I think that's obviously not true, and that it's been heartening to see how readily the new language has been taken up by the GI community. Conversely, I would say that, to call them all disorders of gut-brain interaction and to sort of inadvertently prioritize or make primary the idea of the gut-brain connection is also unfair. Or painting with a broad brush, let's say. I mean, I think at the level of semantics, what I find most productive in talking to a patient with whom I think IBS is a relevant consideration is to say that irritable bowel syndrome is, at the end of the day, an expedient and crude clinical diagnosis that probably subsumes 10 different mechanisms or more. And so talking about the various pathophysiologic mechanisms under that umbrella that intersect and are present to a greater or lesser degree from one patient to the next, I think is a useful starting point. But that being said, it's a clinical history and the vibes of a patient, meaning the vibes they give off and the vibes that they also feel about their care, that can inform the best path forward in terms of prioritizing which mechanistic pathway to follow versus another.
Yeah, no, absolutely. And I think well, you touch on a number of topics there, but this idea of drawing distinction between a pathophysiologic disturbance and an anatomic abnormality, I think, is tremendously important, but that branches out a little bit further into an area that we are focused primarily on day in, day out at CDI, but it sounds like you're incorporating it to your daily standard of care as well, which is a biomarker-based approach to being able to diagnose some of these disease categories. And, I think historically it's always been on an anatomic disturbance side of things, if you can scope, if you can find a blockage, if you can find inflammation, that was the diagnostic pathway. If you weren't able to do that, it always historically has been this diagnosis of exclusion and taking a more empirical approach and using a symptom-based diagnosis. And I think we are now at a place where the science and the technology have caught up and are starting to integrate in a truly fascinating way, but also a practical way, a way where you actually are able to differentiate between some of these different pathophysiologic disturbances. If a patient who is absent alarm signs and is not IBD is presenting with diarrhea, and then 9 other patients come in with the same presentation, they could all have diarrhea for 8 different reasons, but there's 10 patients there. It's not all the same reason. So using things like new diagnostic modalities, tech-based applications to be able to better categorize and index these patients, I think is tremendously important. And there's a question built in here, which is, amongst those new technologies and diagnostic strategies, if you will, to better differentiate these patients, what challenges do you face when trying to differentiate between things that look so similar? IBS, SIBO, malabsorption, GERD, whatever it might be. And then how do you navigate some of those complexities in your clinical practice just on a case-by-case basis?
Yeah, it's a good question. I think, I might quibble a little bit with your sense of the readiness of the field for clinical action. I mean, certainly the science is exciting, but, whether it's ready for prime time on all of the domains, or really any of the domains that we're most excited about, I think, this is where the challenge comes up. Like, how can we best deploy these technologies, and with what degree of accuracy can we pursue therapies based on the data provided by those technologies? And I think all available diagnostic technologies thus far, in terms of biomarkers that would specify a phenotype of IBS that would then lead out to a particular therapeutic avenue, come with heavy interpretive caveats. So in terms of how that challenge manifests in clinical practice, I mean, patients will come bringing the results of tests that other providers have ordered, both within the orthodox medical space and in outside that medical space. No judgment there. Certainly, biomedicine is a bounded practice and a flawed practice, but it can be challenging to help a patient interpret those data when they've developed opinions about them, and particularly, have been told by other providers or through their own reading that these are that this is gospel. Like I have SIBO, or I have dysbiosis based on a stool profile from a fringe for-profit laboratory. So it's as much a challenge to unmake a diagnosis as to make a diagnosis. I think in my practice still, it's frustratingly empiric. The therapeutic strategies that I employ, it's, a lot of, if not this, then this, and then if not this, then this. So that too is a challenge. I mean, patients come to a doctor hoping for a clean diagnosis and a single prescription that will fix their symptoms or at least improve them. And so having the conversation that we're often still defaulting to a guess and check model in today's practice is also a challenge. But, hope for the future for sure.
Yeah, no, I think that's a very honest and refreshing answer. And this patient population is very disenfranchised. Many times you're not the first provider they're seeing. You're not even the first specialist that you're seeing. You may be the third, fourth, or fifth, and that's after a line of primary care visits and the like. So they're actively seeking answers, but not always necessarily getting them. And I think bridging some alternative approaches too, even to outside of diagnostic approaches, therapeutic approaches, bringing diet into the fold and just lifestyle and wellness management. And that might actually be a good segue into one of the conversations I had later on in the discussion. But we're hearing a lot about this kind of multidisciplinary approach to managing the DGBI patient and incorporating in some of these ancillary specialists, dietitians, nutritionists, and lifestyle coaches and the like. I'm just wondering, is that something practically that you, I guess, A, support, and then B, if so, have begun to integrate into your own practice? Do you see the value and benefits of that, or are you still waiting for that to kind of prove itself out as well?
100%. I think that multidisciplinary paradigm holds true and holds value in my practice. The only limitation for me is access to those resources. And I practice at a university setting where we do have, luckily, a lot of resources at our disposal, but they're not a perfect set of resources. We've got dietitians on staff that we have ready access to, but we could always use more behavioral health support, psychologist support, social worker support. But in general, I think a multidisciplinary approach is great. And in terms of interventions that I can enact on my own, the non-pharmacologic approaches, I think, are a wonderful resource. And certainly it's not medicine for medicine's sake that I subscribe to. It's often just because that's where evidence-based medicine points us to. Like that's where there are data to rest our recommendations on. But increasingly, the non-pharmacologic interventions are developing an evidence basis, and that's really exciting. Whether it be an exclusion diet or particular whole foods. There's just recently a paper published on the utility of kiwi fruit for constipation and irritable syndrome. And herbs and supplements are being studied in placebo-controlled trials. So all of that's great. I think the end result is just a broader suite of therapies and a higher likelihood of efficacy for the full suite of IBS patients. And to your earlier point, I think bringing some of these previously separate therapeutic worlds into conversation is only a good thing. The sort of orthodox medical specialists and the non-pharmacologic practitioners, I think that's great.
Yeah, absolutely. And then I think kind of bridging the divide between those two to try to create, as best as possible, some feedback loops between provider and patient too is going to become increasingly more important. One of the key takeaways I have every time I have a conversation with a practicing gastroenterologist around the country, which is daily, is that they get 15, 20 minutes with their patients once a day, one time every couple of months, and everything else about what is happening in that patient's care continuum is happening outside of their office. So it kind of goes back to this idea of technology is not the silver bullet. There is no silver bullet, in any of this. It has to be a multidisciplinary, multifaceted approach to treating some of these cases, and especially the most complex ones. But I'm wondering if you're seeing the added value in that. Is there any one specific application or technology that you have seen any benefits of deploying, or are there any other means or applications that you see potentially in the future to be able to communicate in a more effective or efficient way with your patients outside of just those 15 or 20 minutes you might get with them physically in an exam room?
That's a great question. I think time is probably our most precious resource in the clinical setting, and I certainly wish I had more of it. I do not have a perfect solution. I think in our health system, we utilize a patient portal for intervisit communication. That serves well enough for certain patients, but there's certainly those who don't have ready access to a computer, who don't feel technologically savvy, and there's certainly questions that don't really lend themselves to that quick email-based format. So I guess no, there's no sort of perfect communication modality or perfect solution to that problem that I found. And it comes back to sort of the heterogeneity of IBS, the heterogeneity of this patient population. That some patients are good with visits every 6 months or so, and some patients, particularly early in their course, really have a lot of questions. I think maybe to go back to the multidisciplinary team-based approach, like that is probably the best available solution, to rely on other folks whose interventions are designed to take place on a shorter time course and with more intense time commitments for the patients who need it.
Yeah, no, that makes a lot of sense. Maybe just one caveat to that question too is to what extent are you kind of depending on these patients to be compliant with whatever treatment strategy you may recommend? Again, in the conversation that we're having ongoing with providers and patients, we're hearing all the time, FODMAP, for instance, is great, but only to the extent that the patient is able to comply with that diet over an extended period of time. And I think, the same would go for, therapeutic strategies, rifaximin, or anything else to eradicate bacteria. If you're not adhering to the treatment regimen, or you're not adhering to that dietary modification, or whatever it may be, for the time that's been prescribed, then you really can't expect to increase the quality of life to an order of magnitude that you would like, for instance. So I'm just wondering, in the care continuum, it always is seemingly the patient is totally and entirely dependent on the provider. But in a DGBI patient, to a certain extent, the provider needs to be able to depend on the patient to be doing the right thing outside of their office as well. So, that's kind of a general question. You may not have a tactical approach or strategy there, but I'm just wondering, I guess, maybe to the extent that you even think about it.
Yeah, I think it's I don't know that it's terribly specific for DGBI care. I mean, I think it's more sort of a therapeutic style kind of question. Like, I think of most of my therapeutic relationship as a partnership model, or the aspiration is a partnership model, that we're sort of, there's no hierarchy necessarily. Like, I'm bringing clinical expertise to the table, but they're bringing their experience to the table. Their stuff, I tell most of my patients that they know themselves best. To your point about meeting these people for only 20 minutes, I can only, I'm forced to make assumptions about what's going on with them. I think it is the upside of a DGBI diagnosis that while quite life limiting, it's not life shortening. And so that relaxes me a little bit too, in terms of that partnership model. If a patient deems a certain therapeutic approach non-viable, then it's non-viable, full stop. We move on to another. I mean, we certainly don't have an infinite list of potential interventions, but this too is why it's heartening that more and more are coming up. It just gives us more options. to offer patients. But there is data that efficacy is higher when patients are involved in their decision making, and so I guess I worry about it. I think the first formulation of your question is like, to what extent do you worry about this or feel frustrated by it? I worry about it if there's not a foundation of honesty. If a patient's telling me that they're doing something that they're not doing, I think that's a real impediment to care. But as long as we're candid about what is and isn't working, then I think there's usually a path forward.
Yeah, and I don't think that is the issue. I mean, go back to this idea of these patients being truly disenfranchised, but very much empowered to find answers. I don't think they have any incentive to be dishonest, but it's just difficult. I personally have tried the FODMAP diet, for instance, and it's just hard. So it is, it's something that might not be discussed all that often. Patient compliance, for instance, is it something that may be top of mind for practicing clinicians? There's a lot of other things going on, but it can matter in just in terms of overall cumulative quality of life improvements. And these aren't fatal disease categories necessarily, but they're wildly disabling. And I was just reading a really interesting study in Europe about just absenteeism and presenteeism in the workplace, and it was remarkable, just the numbers in aggregate of missed work days based on these types of issues. So I don't think they can be dismissed in any way, shape, or form. Maybe tying this all up, Dr. Ahuja, I guess macro level trends. There are existing diagnostic strategies, there are existing therapeutic approaches to DGBIs, but I also think there's a much more keen interest in this area amongst practicing gastroenterologists just at large. A lot more data being published, a lot more validation around specific strategies, new criteria being published by ACG, AJ, et cetera. I'm just wondering, again, at a macro level, just how you see all of this playing out, maybe use a 3 or 5 year window and how some of these emerging technologies integrate to benefit the patient.
Yeah. I don't know if we'll see kind of a distillation or a consummation of these trends in 3 to 5 years, but I think continued emphasis on precision, perhaps less at the level of the individual patient and more at the level of phenotyping. Sorry, I guess phenotyping the individual patient, but not each patient is their own disease. But how can we meaningfully cut up a disease like irritable bowel syndrome into its constitutive parts that would each be conducive to a different therapeutic strategy? So precision with an eye towards refining our diagnostic terminology, I think is one. And then employing big data to answer some of these thorny questions and really get at some of those phenotypes in a rigorous and accurate way. Those are some of the trends that I'm most interested in following, but I'm also interested in being surprised. I think new stuff is coming up all the time that I hadn't thought about.
Absolutely. And a personalized and precision-based approach to some of these diseases, I think, is the ever-evolving way of the world. So hopefully we can contribute toward that in a meaningful way. And I think this is probably as good a place to stop as any. I wonder, Dr. Ahuja, are there any just kind of final thoughts you want to leave the audience with before I give my closing remarks here? The floor is yours.
No, that was great. Thanks so much for the opportunity. Glad to chat with you today.
Great. No, it's our pleasure. Thank you to Dr. Ahuja for joining us. Thank you to our audience for tuning into the Modern Gastro podcast. We are dedicated to the ever-evolving world of functional GI disorders. Today, we delved into the intriguing topic of IBS and its relationship with SIBO. Remember, the GI field is continuously advancing. Staying informed about the latest diagnostic and treatment strategies is crucial in delivering optimal care to patients. We hope our discussion has provided valuable insights for the GI community, and we encourage you to continue the conversation beyond this podcast. Connect with CDI on social media, engage with fellow healthcare professionals using the GI community hashtag, and share your experiences and expertise. together we can drive progress and enhance patient outcomes in the realm of digestive health. So thank you once again to Dr. Nitin Ahuja for joining us on this insightful journey, and stay tuned for more thought-provoking discussions from Modern Gastro. Until next time, thank you and signing off.